Great. So thanks very much. If we could get it on slideshow view, fantastic. Yeah, so we're going to be covering a lot of ground here in a relatively short period of time. So I wanted to come back, and I got yelled at when I used the term heat map because I was told this is not a heat map, it's a density plot. But be that as it may, by you, I think. I wanted to just go back and say that I'm going to be talking about the right hand of this. So this is improving effectiveness in healthcare, and you can see for our last strategic plan that there was expected to be a handful of things merging into this area, which I think is exactly what we're seeing. But if we move forward, you can see that we're really going to be launching into this healthcare thing, which is, I think, what we're all about and which I've been asked to talk about. So I'm going to give you an overview of implementation of genomic medicine programs. And this was extracted from a review article that appeared earlier this year. I identified 4 areas of focus: diagnosis, pharmacogenomics, oncology, and population screening. This is not a comprehensive review, but what it's based on is actually published information that people have put out in the peer-reviewed literature. And I specifically selected the exemplars that presented information on how they did the implementation and whether or not they were defining and measuring outcomes. In the article itself, I included 1 U.S. program and 1 international program, but I'm only going to be talking about the U.S. programs for this talk just because of time. I wanted to start with diagnosis because, in my view, this has always been the engine for discovery in genetics. We find a patient, we don't understand what's going on, we take advantage of constant new technology, we have 1 foot in the clinic, 1 foot in the research laboratory, and we sort it out. So on the left-hand side are examples of this dating back to 135 Common Era. But what this really represents, and Heidi alluded to this, is it's a learning healthcare system, and we're comfortable doing this in genetics and genomics. The idea that we're not going to be able to have this right from the get-go, that we have to put things in, test them out, measure, improve, and do this virtuous cycle until we really have something that works. And then each new technology or new understanding knowledge is incorporated into this. So this is really a constantly evolving thing. And so my perspective is that we have to be thinking about this using this learning healthcare system model. So it was nice to hear Heidi say the same thing. So to me, the biggest exemplar, which again Heidi alluded to, is the Undiagnosed Diseases Network. And I wanted to highlight 1 publication from one of the sites, the Brigham Genomic Medicine Program, because they published their experience with the implementation of their program. And they covered different components of the evaluation workflow, which included case ascertainment and informed consent, genomic sequencing and data analysis, causality of candidate genes, crowdsourcing and matchmaker analyses, and reporting evidence to the referring clinicians, all key aspects of implementation. They then presented some of their outcomes data, an evaluation of 244 families using massive parallel sequencing on 122, and at the time of the publication they had achieved a causal diagnosis in 30 with a candidate diagnosis in an additional 48, but there were no outcomes that were presented beyond the diagnostic rate, alluding to what we were just discussing. Now, the Undiagnosed Diseases Network as a whole also published their 2 years of experience within the last year. And they have evaluated 1,500 patients, of which 601 were accepted for evaluation, and about 2/3 of them have completed their evaluations. Again, about 35% of them achieved a diagnosis, which is pretty extraordinary given the amount of workup that these individuals have had prior to coming into the program. But massively parallel sequencing accounted for about 3/4 of the diagnoses. They noted that 21% of the diagnoses led to a recommended change in care, but they did not publish details about the nature of those outcomes. Now, if we move on to pharmacogenomics, I want to highlight a publication from the Mayo Clinic Center for Individualized Medicine. And again, they gave a very detailed explanation of how they implemented their program, focusing 8 interrelated functional components that they deemed to be essential for success. And they were then actually able to move this into a full clinical implementation. And at the time of this publication in 2017, they had over 1,200 providers that were on the system, and they had 3,800 100 patients who had been affected by an intervention in the pharmacogenomic realm. But unfortunately, they did not publish any outcomes or define what are the outcomes that we are really looking at to be able to do that. And so to look at outcomes, there was a publication that came out of the Translational Pharmacogenetics program, Implementing Genomics in Practice, that looked at implementation across a research setting across 8 different sites. And they defined outcomes, but they defined them in these 4 domains: scientific, educational, financial, and informatics. They had no patient outcomes that they presented as being defined or collected. However, one of these projects subsequently published on outcomes, which included data from the NHGRI-funded IGNITE sites related to implementation of CYP2C19 for clopidogrel, where they confirmed what multiple studies have shown: an adjusted hazard ratio of over 2 for major cardiac events if you're a poor metabolizer of 2C19 and you're given clopidogrel, which is a prodrug which requires conversion. And they found no difference in events if you were placed on an alternative medication, if you were a poor metabolizer, compared to those that were normal or intermediate metabolizers on clopidogrel. Dan Roden just published an editorial to a randomized controlled study saying, CYP2C19, isn't it about time, or something to that effect? And it is about time. We should be doing this. Now, normally I wouldn't be talking about oncology at an NHGRI meeting because they always tell me, well, that's the NCI stuff. But this is such a great example of how to do implementation and outcomes right that I really wanted to highlight it. And this is the Intermountain Healthcare Precision Cancer Genomics program. And in this program, they systematically evaluate patients with recurrent or metastatic solid tumors who have failed first-line therapies. They molecularly characterize the tumor to identify somatic mutations, and they've created an infrastructure to evaluate these mutations. And it was based on stakeholder engagement with system leaders, payers, and other stakeholders. At the outset, they defined the outcomes that they would collect for the patients who were treated through the program, and they created a system to collect and analyze those outcomes. And I wanted to highlight 2 papers that have come out of this group. In 2017, they did a retrospective evaluation of the impact of molecularly targeted therapies on progression-free survival and healthcare costs. They did a matched cohort study, retrospective, where they looked at 36 patients treated through this precision oncology and 36 treated by standard of care. They improved the progression-free survival from 12 weeks to 22.9 weeks. And interestingly, the cost of care per week was cheaper in the intervention group than in the control group, although the difference was not significant. Now, they extended this study in 2018 to look at a broader range of outcomes. And in this case, they restricted it just to their health plan patients, so they had full data. So this is 44 patients, the same sort of a cohort control. And what they looked at as median overall survival was nearly 1 year in the precision oncology group compared to 26 weeks for the control group, highly significant. They again confirmed that the average cost per week of therapy was cheaper in the precision oncology group. And what was really fascinating was the cost of care in the last 3 months of life was 7% lower in the precision oncology group, which more than offset the increased pharmacologic costs of the precision oncology program. Now, it's important to recognize that the total cost of care in the precision oncology group is higher because they live twice as long, okay? Dead people don't incur healthcare costs. It's just a dirty little secret of healthcare economics. But when they engaged with the payer, they said, we understand it's costing us more money, but the survival benefit that you're demonstrating is, from our perspective, a high value that we are willing to pay for. So now all patients that are covered by the Intermountain Healthcare Health Plan are eligible for this program. Lastly, I want to talk about population screening, and in our self-interest, I'm presenting the program that I'm most familiar with, which is our MyCode program. These numbers were updated as of yesterday. Over 250,000 consented individuals, and we have about 65,000 exomes that have been analyzed, and we've returned results to nearly 1,200 of our participants. We have focused this on about 60 genes, 30 conditions, with the Tier 1 conditions as defined by the CDC, hereditary breast and ovarian cancer, familial hypercholesterolemia, and Lynch syndrome being the ones that we are really focusing most heavily on. One note that I will make here is notice that we have 1,176 results from 1,168 patients. 8 lucky patients, we found 2 things. And I want to talk a little bit about some of the outcomes that we're putting forward. So firstly, we had presented a poster, Adam Buchanan, one of our program leads, presented a poster at the ACMG meeting last year that showed that nearly 90% of individuals with one of these Tier 1 gene variants detected via genomic screening were previously unaware of their variant. This is probably not surprising, but many of them had a personal or family history of conditions that should have raised some clinical suspicion, perhaps. 2/3 of the patients actually used this information to perform relevant disease risk management. Now, we also published in 2018 the Manicam reference about a deeper dive into hereditary breast and ovarian cancer. And to summarize this, we identified really 2 significant care gaps. One of these is that there are a significant number of patients who are actually meeting the clinical criteria for BRCA1 and 2 testing that are not being tested. About half of them are not being tested. The second thing that we noticed is that these clinical criteria are very insensitive. Only about half of the patients who have one of these pathogenic variants in BRCA1 or 2 actually meet current clinical criteria for testing. So about 75 to 80% of the patients that are actually at risk for a HBOC-related cancer are currently unidentified, representing really lost opportunities for prevention. And to drive that point home, here is some recent data on post-disclosure diagnosis. So here's a total of 41 patients with one of the Tier 1 conditions where, on the basis of an evaluation that was initiated after the return of results, we found that they had evidence of disease. So in FH, atherosclerosis, peripheral vascular disease, HBOC, breast cancer, prostate cancer, and some other cancers, and in Lynch syndrome, colon adenomas. So these are people that have subclinical disease, they're not aware of it, and with this intervention we've actually identified it. So my initial conclusions are that we're clearly seeing evidence that genomic medicine is beginning to emerge into clinical practice, but there are really few examples right now of pure clinical implementations. Most of the programs that I've talked about are a mixture of research and clinical research implementations. Collection and publication of outcomes is lagging. I don't think there's any other way to put it. We just don't have enough of the data. But I think the biggest problem, and this is what I entered into my opportunity chat earlier, is that we're treating sequencing like we're treating every other laboratory as a one-off, which is really stupid because the germline sequence doesn't change. So I wanted to end my talk with 4 really quick vignettes that I think highlight opportunities if we use sequence data and maintain it in a usable format. And these are all 4 from the MyCode program. One is reanalysis, which Heidi alluded to. So we've now done a second analysis of those 65,000 exomes that I mentioned. And I'm not going to go through this, but here are all the ones where we found a variant on the second analysis that was not found on the first analysis. Most of these are related to new variants that are being deposited in ClinVar, star 2, star 3 level, highly confident variants. So here's a bunch of people that we didn't identify that we can now identify if we do this on a periodic basis. The second thing is that there's pharmacogenomic information in this exome data. And so we did an experiment using our eMERGE participants that were sequenced on the eMERGE-seq platform where we had pharmacogenomic variants, and we did a concordance study looking to say if we looked for these variants in the exome, what was the likelihood that the exome called it right? And what we find is extremely high concordance, at least for these genes, and the variance in these genes compared to the emerge-seq data, which is highly important. Now, of course, there are some genes that we just can't pull out of exome, like CYP2D6, which is unfortunate because the Mother Nature has decided that that's going to be one of the most critically important pharmacogenes and made it the hardest to sequence. So, such is life. Now, this is, for some reason, is not projecting. That is really unfortunate, and nor is the next one. Okay, well, theater of the imagination here. So what this table was supposed to show was that we said, well, we've got the sequence. What if we were to be able to go through, look at pathogenic variants in genes that are known to be associated with disease, but not the common things, so sort of rare disease genes. And we identified a number of patients that had, star 3 level variants in ClinVar that were pathogenic in genes associated with disease. Only one of the 8 patients that are on this table had actually had a clinical diagnosis, and there were 4 others that were represented between these brackets that were highly likely to have the actual condition, but had never seen a medical geneticist. So we talk about undiagnosed disease, but the problem is we're looking at undiagnosed disease that somebody has said, oh, this is an undiagnosed disease, and made a referral. There's a ton of people out there that aren't being referred, and the number one person here was a person that had a variant in COL2A1, which is associated with Stickler syndrome, that since the age of 5 has had retinal detachments leading to the loss of one eye, progressive myopia, sensory neural hearing loss. She's now 21 years of age. She's never been evaluated through genetics, and we would have identified that diagnosis on the basis of a chart review had we had a chance to see it. So there's a lot of genetic disease out there that's not even coming to anyone's attention, and analyzing sequence would be the way to do it. And then the last one is, how do we use this in real time? So we've got the sequence, and so we did a study in Nephi Walton where we looked at patients that had a diagnosis of epilepsy due to a genetic cause. And we looked back through their medical records and say, if we had the sequence that we analyzed at that time to look for a genetic cause of epilepsy at the time of the initial presentation, how much time would that save us? On average, we would have diagnosed that 3.5 years earlier. What was most disturbing was that 50% of these individuals received anti-epileptic medications that were contraindicated based on their genetic finding. And 30% of them received an MRI, which has almost zero utility, but which all payers pay for prior to testing. Whereas if we'd had the sequence, and that when that person presented with a seizure, we did a virtual panel of epilepsy genes, we could have diagnosed these individuals immediately and immediately initiated care. So I think these are opportunities to really rethink how we use the sequence data. So I apologize I went a little over since I had to describe something that otherwise you would have been able to see. But I really want to thank all of you who are actually publishing your data on implementation and outcomes. This is critically important. I want to thank all of our MyCode participants, all the incredible people at our genetic screening and counseling program that are being led by Amy Sturm, Adam Buchanan, David Ledbetter, and others, and then our collaborators at Regeneron, for which this would not be possible. So thank you very much.
Questions or comments?
Hi, Mark. My question, I have a detailed question and a bigger picture question. The detailed question is, how did you pick which genes to look for the rare diseases in your population?
That was a great, it was not systematic. It was just sort of, our colleagues at Regeneron who have a rare genetic disease project said, well, we looked at these, we found these things, could you look in the electronic health record? So we are beginning to look at how we might do that more systematically. So, but I would say it was sort of a random sample.
Okay, thanks. And my bigger picture question is, would you be willing to tell us a little bit about what you've learned about educating physicians?
Sure. The key, and when people ask us about the success of our program, I think the key has been 2 things, which is the early and substantive and ongoing engagement of all relevant stakeholders, which includes our patients, primarily, where we spent 2 years prior to launching the program with focus groups and interviews and community meetings and everything to say, what do you really want from this? But then also on the physician side, to say, this is what we're looking to do, what do we need to do? And then when we begin to implement it, to say, how can we work this into your workflow? What sort of infrastructure do we need to provide to support you so we're not leaving you? We don't want to send them a result and say, hey, good luck with this. So we look at this as really partnerships with our patients, partnerships with our clinicians. And so it has to be done early, it has to be done often, and it has to be done continuously.
Hi, Mark. That was a good talk. Thank you. I'm curious about the epilepsy stuff that you presented at the very end. Did you look at, if you just sequenced everybody who presented with epilepsy first, what would the genetic diagnostic yield be of that one feature?
I don't think that study's been done. I know that there have been some studies that have been published by Epi4K and now Epi10K that looks at the more severe forms of epilepsy, like the early epileptic encephalopathy and some of the unusual seizure types, where they're showing diagnostic rates of 30 to 40%. So, but I think the important part of your question is, I'm not interested in sequencing everybody that presents with epilepsy. I'm interested in having the sequence on everybody and using it. So rather than just saying, well, we're going to do population screening, to basically say, I now have an indication which raises the prior probability that there may be a genetic cause. And now it's less important what the actual prevalence is. It's the idea that we can, at a very low cost, analyze this and potentially find things that would have a very a strong opportunity to improve care. So I don't want anybody to come away with the idea that I think that anybody that presents with anything should have a sequence. I think we're moving to the idea that at some point in the future we're all going to have a sequence. But I think the other takeaway is we're generating a lot of sequences in clinical care, but we're using them the wrong way. We're using them as a one-off and say, oh, we made a diagnosis or we didn't. And then we just throw the data away like it's a serum sodium. And we need to stop doing that. We need to think about how we persist the data and use it for multiple indications as that patient goes through their lifespan. That, to me, is a real opportunity that should be represented in the next strategic plan.
Jeff?
Hey, Mark. It's Jeff Ginsburg here. So about 5 years ago, there was a paper published showing that about 10 years after incorporation into guidelines, EGFR testing was only being done in 10% of community-based practices for patients with lung cancer. And I guess my question is, how do we address this similar type of issue for genomic medicine, both getting these into guidelines and also dissemination to the community?
Yeah, I mean, that's the primary implementation question, and I think the reason that in a lot of cases why these things are not moving into clinical practice is less about evidence and more about the old story, you know, how many physicians does it take to change a light bulb? Change? You know, we're used to doing it the way we've always done it. And so I think the opportunity is, and if you look at the successful systems like Intermountain or Mayo or that, why are they able to do this? And I think the reason they're able to do it is because they've already accepted the fact that we can't do medicine like we've always done it, which is the doctor's the head of the ship and anything that they say goes, and it all has to reside here. It's about systems of care. And if you have systems of care, then you can take advantage of those systems of care to be able to implement new evidence when it becomes available. And you're not as reliant on the inertia of, well, the professional society has to write a guideline. And when they write a guideline with weasel words that, well, you maybe should consider this. Well, what am I supposed to do with that? So those are the sorts of things that it's really, and it's daunting because it gets to the question that you asked earlier, which is, how do we do this? And it's really much more about a cultural change of how we care for medicine, moving to this learning healthcare systems model, of which genomics can be a part of that. But to expect that genomics is going to drive that cultural change in medicine, I think is a bit of probably a fairy tale.
So Mark, one of the missed opportunities here is the clustering of disease in families. And I think in your population sequencing, our efforts the data is that the yield of cascade testing is very poor. And I think we need to recognize that and have systems in place so that if we find a proband, we then have the opportunity of really going beyond and detecting many more people that might be affected.
Yeah, I think the cascade testing is critically important. And if you look at most of the cost-effectiveness studies that have been done in some of the more common disorders, the cost-effectiveness comes from identifying the relatives, not from making the diagnosis and the proband. So you're spot on there. It's embarrassing when we looked at our data that probably right at the present time using, again, traditional methodologies of relying on the patient to communicate to their relatives. At best, we're getting about 15% uptake of cascade screening, which is a huge missed opportunity. So we are heavily looking at how do we re-engineer that system to be able to take advantage of other types of approaches so that we can hopefully get higher penetration of cascade testing, because that is such a straightforward and easy thing to do that we really need to be able to focus on that.
Dan?
Mark, that was a really nice summary. What is the role of the professional societies in all this, the professional subspecialty societies? So I should know the answer to this, but I don't. Are there guidelines from the cardiology community that say in someone who has a myocardial infarction before age 50, FH testing should be done, class 1A indication, or in someone who presents with a, quote, non-ischemic cardiomyopathy, genetic testing should be done? That's one thing. And then comment on the role of professional societies in pharmacogenetic
Yeah, so
barriers to testing.
yeah, I certainly have not done a comprehensive review of professional society recommendations, but to the best of my knowledge, there are almost no explicit testing recommendations from professional societies relating to genetics. And in the particular instance of the cardiovascular community, I know that there are some guidelines specific to FH and that those do reference genetic testing, although I don't think they're saying you need to do it. And those were just out last year, and you kind of wonder, well, why are we not, kind of moving forward with that? Pharmacogenomics is a bit of a different animal in that CPIC, the Clinical Pharmacogenetics Implementation Consortium, does have evidence-based guidelines out there about how to use the information. Now, the difference in those between other guidelines is that it assumes you have the information, and it provides the evidence on how to use it. It does not actually provide evidence about who should be tested. I think one of the groups that clearly has to be involved here is FDA. I mean, at the present time, with all the label information on pharmacogenomics, FDA has a single pharmacogenomic indicator that they mandate testing, and that's HLA-B5701 prior to the use of abacavir. And why, with all the evidence that we have about clopidogrel, why isn't CYP2C19 testing required if you're going to use clopidogrel? The evidence is there, and the FDA has the ability to do that, but it's not being done.
Can I supplement that? I wonder if there's a cultural, you mentioned a lot of cultural differences. I have the impression that medical genetics in general is very different than something like ACOG. My impression is ACOG goes out aggressive and early and hard on implementation, and they push things, whereas I sometimes feel our field is intrinsically very reticent.
Yeah, I think that's fair, and full disclosure, I am not wearing my hat as the president-elect of the American College of Medical Genetics and Genomics, so nothing to disclose there. But I think one of the things that I see as being very important from the college's perspective is we are now investing in actually full evidence-based reviews for all of our guidelines. And I think our guidelines, for the most part, have been based on professional opinion, which is sort of the lowest level of evidence, eminence-based guidelines as opposed to evidence-based guidelines. So now the fact that we're going to be incorporating systematic reviews of evidence to inform our guidelines, I think may allow us to be a little bit more proactive in terms of saying, this is really something that should be done.
Again, joining you in full disclosure, I wear a second hat too. I do clinical cancer genetics, but I'm also a breast surgeon. And so back to the physician education point that I think is a major barrier. When you mentioned that, I think you said 25% of the patients with a tier 1 mutation did not follow up with appropriate screening and surveillance. where's that breakdown? And that's where the clinicians go, yikes.
Yeah, well, we're definitely, again, it's a glass half full, glass half empty, right? The fact that 75% of them are actually doing it is probably a really good thing because of the care gap that I mentioned. There's a lot of people that aren't currently following the recommendations, and many of them are willing. But you're right, there are some people that even when they either don't want to have the information or they have other things, and so we are trying to systematically look at what are the reasons that people are not following through on the recommendations. But that being said, I think the health behavior change that we're seeing early on in the program is substantially larger effect than almost all other sort of interventions that have been looked at. So it does appear that people are paying attention to this in somewhat of a different way. So a lot more work to be done there to really understand those factors. But again, I think we tend to focus on the negative, which is why aren't these people doing things? Focus on the positive. 2/3 of people are doing something that they weren't doing before that has an opportunity to improve their health.
If we have quick things.
Back to the topic of sequencing someone's genome and then keeping the data to reuse it throughout their lifetime. I mean, in the previous talk, there was the issue of a physician not wanting all the data because of the sort of implications of not failing to report something that was in that genome. Like, how do we deal with?
Well, I'll have to tell you, I have very little patience for physicians that say, I don't want the liability. You have MD or DO after your frickin' name. That means you are committed to do right by your patient. And we should not be driven by liability. We should be driven by, this is information that could benefit this patient at some point in time. Now, that being said, we have to have systems in place because we can't rely on the physicians to remember all of this stuff. And that's why building automated systems like I talked about with the epilepsy, I don't want my neurologist to have to say, gosh, should I look at the sequence, should I not look at the sequence? I want the electronic health record to say, new onset seizure, boom, automatically sends a query to the sequence. This patient has a sequence. We run a virtual epilepsy gene panel. Hey, we found something in SCN5A. That comes back to the clinician, say, we have a reason that your patient has epilepsy. This is the confirmatory testing that you need to do. This is the medication you should use. Do not use this medication. And we are available to consult with you if you need us. That's the system we need to build. But the idea that we're again still thinking about the whole idea of physician as captain of the ship. And it's why healthcare runs at a half a signal reliability. If we come in, it's a 50-50 chance if we're going to get the right care or not. And that's been documented in multiple occasions.
Did you have something, Jillian? Any quick ones? Okay, let's go on. That was great, Mark. Thank you very much.